and Dr. Subramanian Swaminathan has joined. So should we then start, sir?
I think you want to wait for him. Who's left? Everyone's come
No,
here, right?
yes, because Dr. Sarnakar said he will be joining little late, and Dr. Matteo Bassetti also said he will join in between and to continue with his video.
Let's start because we have 1.5 hours. Hi, everybody.
Yeah.
Hi.
So, Viraj?
Hi, ma'am. One moment.
Vaishali, should I just tell the panelists the flow quickly for a second?
Yes, sir.
Yeah.
So, sir, initially after my just quick welcome, I'll hand over session to Dr. Mehta, sir, and he will be introducing the entire panel and Dr. Matteo Bassetti. Then we will have a pre-recorded session of Dr. Matteo Bassetti, and then the panel discussion will start, with which Dr. Mehta, sir, will be moderating and taking it ahead. And by that time, Dr. Matteo also will join, and Dr. Swarnakar, sir, also will join. So, is that okay, sir?
Yeah.
Fine, sir.
Okay. Excellent.
Okay. So, Viraj, give me the countdown and then we start.
डॉक्टर गुप्ते तुम्हाला मी फोन करतो 1-2 मिनिटांना.
Vaishali madam, we are live now. Over to you.
Good evening, everyone. I am Dr. Vaishali Gupte, Director Medical at Cipla, and it gives me great pleasure to welcome you to this webcast on role of cocktail antibody drug in COVID-19. Second surge of COVID-19 has severely impacted us, and many new drugs are being introduced to fight against this COVID-19. Cipla has recently introduced casirivimab and imdevimab monoclonal antibody cocktail for treatment of COVID-19 in collaboration with Roche. This antibody cocktail has shown to reduce the risk of hospitalization and mortality in patients with mild to moderate COVID-19 disease who are at high risk of progressing to severe disease. The objective of today's webcast is to discuss on all evidences, positioning of this drug, and clinical experiences pertaining to the use of this antibody cocktail. We are extremely honored to have all eminent faculty members for this webcast today. We have with us Dr. Ravindra Mehta, sir, to moderate this entire session. Dr. Ravindra Mehta, sir, is Chief of Pulmonary Critical Care and Interventional Pulmonology at Apollo Specialty Hospitals, Bangalore. I really thank him for accepting our invitation, and I hand over session to him to take it ahead from here. Thank you so much.
Thank you very much, Vaishali, for first of all organizing this, calling us here, and what promises to be a very interesting session. So I think in the interest of time, I'll just share my screen and we will start off with the program flow. Can you see my screen? Is my screen visible?
Sir. Yes, sir.
Okay, fine, sure. So good evening, everybody, and it's nice to be here at a time when COVID seems to be taking a little dovetail in the country. However, the story of COVID is replete with agents which have been planned a while ago and are surfacing now. And we don't know at what point which agent will be useful. And this is where the science keeps progressing more rapidly than we've ever seen in our lifetime, as new drugs keep coming, old drugs, and the panelists. Today, we are fortunate to have Dr. Matteo Bassetti here, who is an infectious disease specialist from Italy, and will be introducing him. And my august Indian panel, which who are all friends and eminent doctors from all over the country. I am Ravindra Mehta, and I'll be moderating this session. You can see the wisdom which we get here. We need this sort of wisdom in COVID-19 to get us through these horrendous and times we have seen as the hurricane hit us unceremoniously a while ago. To briefly introduce our speakers and not spend too much time, Dr. Matteo Bassetti has been speaking on the Indian scene for a while, mainly in the infectious space in gram-negative and gram-positive infections. And he is a prominent international, well-published infectious disease expert from Italy. And he will be taking the first part of the session where he'll walk us through the entire science of this monoclonal antibody cocktail. I'm very fortunate and privileged to have excellent COVID specialists, thought leaders, advisors, and clinicians and practitioners from all over the country. We have a smatter of all specialties. We have Rahul Pandit, who's a prominent name in Mumbai and now recently has been also deputed to the National Oxygen Committee to help the country go through this crisis. Dr. Subramaniam Swaminathan is a very experienced infectious disease specialist with a special interest in transplant infectious disease, and he will be weighing in heavily on many interesting aspects of both this particular medication and aspects of the COVID pandemic. Rajesh is both a friend and a pulmonologist who's played a very prominent role in the Indian Chest Society, besides being a prolific clinician and playing a major role both in policy and in practice in his area in Nagpur. And Dr. Vasant Nagvekar is another infectious disease consultant, also well known on the national scene, who has also been in COVID to the point that he has just left the ICU and joined us. So with such a excellent spectrum of very knowledgeable, savvy, scientific and up-to-date doctors, we will proceed with the session. Today's session flow will be the following. Dr. Matthew Bassetti has sent in his recorded session that will be played initially. After that, he'll be joining us as a panelist along with our friends over here. And the later part of the session, after the first 25 to 30 minutes, a full hour will be devoted to core questions, key questions, which have been collected over the course of the last few days as this drug was reviewed by both CIPLA and other people across the country. And then we'll be taking audience questions also. So with this particular introduction and format, I think we will at this point proceed to the next part of the session, which is Dr. Matthew Bassetti's complete talk on when, how, where of the monoclonal antibody cocktail we are discussing. Vaishali, can we play his talk now?
Yes.
I'll stop sharing my screen. Thank you.
Yes, thank you.
Hello, good evening. I am Matteo Bassetti. I am the chief of the infectious disease clinic in the San Martino University Hospital in Genova, Italy, and also professor of infectious diseases in the University of Genova. So my task today is discussing with you about the potential role in COVID-19 for monoclonal antibodies, with particular focus on casirivimab and imdevimab. So let me start my presentation. These are my disclosure regarding in the past 5 years. But before starting talking about monoclonal antibodies, I like to show you how the disease, the COVID-19 illness, is characterized by viral replication and immune response. So we know very well that COVID-19 in the first stage, in the stage 1, in the first 7 days of the disease, there is a primary viral illness with an important viral load. And this is probably the phase in which it's important to act with antivirals, with monoclonal antibodies, and with other drugs active against the virus. Then we know that we have a severe immunological response in the stage 2 and in stage 3, in which is probably more important to use other drugs like anti-inflammatory drugs. So when we look at the relationship between viral dynamics and inflammatory response, we know very well that the viral load increase in the first days of the disease, and at the same time we have an inflammatory response. And this is the time in which in general is important to act, as I mentioned before, because this is the time in which the viral load increased dramatically, and then there is the evolution of the disease with pneumonia, acute respiratory distress syndrome, and thrombosis. And this is a time, very important time, in which in all the disease, in the mild and moderate disease, the viral load is very high. So when we look at the 3 different phases and the 3 different stages, we continue to know that the viral phase response is here, in which we have in general mild symptoms, in which we have fever, dry cough, but mild symptoms. And again, the potential therapies are represented by antivirals, by monoclonal antibodies. And then in the stage 2 and the stage 3, in the pulmonary phase and the hyperinflammatory phase, is more important to act with host inflammatory response phase drug like anti-inflammatory drugs, corticosteroids, or other inhibitors of the IL-1, IL-6, and any other type of JAK inhibitors. So now I like to discuss the principal topics of my talk, that is the role of the CASI-IM antibody cocktail and the clinical data available, and then the real-world clinical experience. And then I will show you at the end our experience in Genova regarding the use of the monoclonal antibodies. So what do we know about the CASI-IM cocktail antibody? So how the cocktail antibody is derived from a large pool of candidates. First of all, the antibodies were collected from the convalescent plasma from previously infected patients, and also for humanized mice challenged with SARS-CoV-2 spike protein. Then the antibiotics were screened, and they screened for the binding affinity, for the neutralization potency and 3D structure and overlapping epitopes. And then 2 monoclonal antibodies were selected. The first is the imdevimab, and the second is the casirivimab, and simultaneously bind to distinct region of the spike protein. So when we look at the cocktail, this is a very highly potent antibody cocktail targeting the COVID-19. There are 2 distinct antibodies bind non-competitively to the SARS-CoV-2 spike protein, and they prevent virus from infecting health cells, and they using 2 antibodies protect against the emergence of resistance. Very important, the monoclonal antibodies are active against the main variants, including the UK, the South African, and even the Indian variants. So which is the potential role in the treatment of COVID-19 based on the available data? So we know that for the pre-exposure prophylaxis, we have the vaccine, so they act in order not to have the infections. But then we have at least 3 settings in which monoclonal antibodies are useful. First of all, in the post-exposure prophylaxis, in which we can use this formulation that is actually not approved, that is the subcutaneous administration. And then we have the CASI-IM IV in the outpatient treatment and high-risk patients and in hospitalized patients with mild to moderate disease. Obviously, there is no role for monoclonal antibodies in hospitalized severe patients, in which we have role for IV antivirals, for steroids and other immunomodulators. Let's check the clinical data available regarding the monoclonal antibodies. So in non-human primates and rodents, the preclinical data, the monoclonal antibody reduced the viral load in lower and upper airways and decreased the virus-induced pathological impact for treatment and for prophylaxis. The single monoclonal antibody treatment result in escape mutants that evade individual antibodies. And the CASI-IM antibody cocktail prevent efficient generation of the escape mutants. It's important, the combination of the 2 antibodies, in order to act even against the escape mutants, all the one report till now. So under clinical investigation for the prevention of COVID-19, we have at least 3 different studies. Studies in hospitalized patients, the 2066. This is an adaptive trial, phase 2-3 portion in hospitalized COVID-19 patients with 4 cohorts, 1 not required oxygen, One is low flow oxygen, high flow oxygen, and mechanical ventilation. This is the 4 cohorts of patients, and the administration of the monoclonal antibodies has been done by IV, and there is actually an interim analysis. Then we have an ambulatory study that is the 2067. This is an adaptive trial, phase 2-3 portion in the ambulatory COVID-19 patients with 2 cohorts, symptomatic with initial data available and asymptomatic. And again, this is a phase 2 data available, phase 2-3 trial available, IV deliver. And then this is a nice study that is ongoing, and there is an interim analysis for the subcutaneous delivery in 2 cohorts, asymptomatic, non-infected, and asymptomatic early infected, particularly household contacts of index patient with COVID-19. This is a phase 3 trial. Let me show you the data about the first study, that is the 2067, in which CASIA-M in the ambulatory patient has been used. And these are the data. They use different dose of the combination cocktail, 2.4 gram or 2 or 8 gram. And we have the placebo arm, and in ambulatory patients with COVID-19 more than 18 years old positive for SARS-CoV-2, symptomatic cohort and asymptomatic cohort. And these are the results of the phase 2. There was a significantly reduced viral load in both seronegative and particularly in the overall population. You can see very well from the baseline to the time in which the study has been assessed. And then there was also a significantly reduced number of medically attended visits in patients with confirmed SARS-CoV-2. And you can see very well here the difference between the placebo and the monoclonal antibodies. Based on phase 2 data, the following adjustments were made to phase 3. Modification in the tested dose, 1.2 and 2.4 discontinuation of 8 gram, and recruitment restricted to patients with risk factors. 100% of the population for the phase 3. The data has been published for this phase 2 trial in New England Journal of Medicine, and these are the safety report about the cocktail, and you can see very well that the safety was as expected for a full human antibody against an exogenous target, and there were no difference between the use of the monoclonal antibodies and the placebo. The percentage of patients with the hypersensitivity reaction and other serious adverse events were similar in the combined CASI-IM dose groups and the placebo group. The second trial and the second part of the study was the phase 3 of the 2067, in which CASI-IM has been used in the ambulatory setting. And these are some of the key results in the phase 3. And you can see very well, these are the data, and 1.2, the placebo, 2.4, and the placebo. And the patient with COVID-19 related hospitalization or death through day 29, there has been a 70% reduction. 71 for the higher dose, with a P that was statistically significant. And you can see very well even the patients with events that was 1% compared to 3.2. And the time to COVID-19 symptoms resolution was 10 days versus 14 days, with an advantage and a median reduction of 4 days. And the safety assessment as conducted on all available patient data up to 169 days and identified no problem for the safety. What do we know about this study in ambulatory setting, which are the summary of the phase 2 and 3 study? Medically attended visit, significantly reduced in patients with confirmed infections, greater benefits seen in patients with risk factors. Then risk of hospitalization or death, significantly reduced by 70% and 71% versus the placebo, and the viral load significantly reduced in both seronegative and the overall populations, great reduction seen in patients with higher baseline viral load, and the safety well tolerated with no unexpected safety signal. So regarding the study 2066, in which CASI-IM has been used in hospitalized patients, this is an interim analysis. And we have a very nice data, and this is a press release presented by Regeneron in December 2020. And in this study, they include patients age more than 18 years old with SARS-CoV-2 positive or investigator determined COVID-19 symptoms hospitalized for less than 72 hours. And there were 4 population again, 1A, not requiring supplemental oxygen, 1 low flow oxygen, 2 high intensity oxygen, and 3 mechanically ventilation. And they has been randomized 1:1 to 2.48 gram or the placebo. And the results available from patients in the cohort 1, we have the median age of 62 years, 53 male, 40% seronegative and 50% seropositive. And you can see here the reduced risk of death or mechanical ventilation in seronegative patients, futility analysis based, and you can see the odds ratio, and this is very interesting. And there has been a reduction in viral load with the CASI-IM in the seronegative and in seropositive, particularly in seronegative by 0.54 and 0.63 at day 11. And for the serious adverse events, there were no difference between placebo and the monoclonal antibodies, and even the infusion reaction, you can see that was similar but lower in the 2.4 grams. So looking at the summary of the interim analysis of the CASI-IM in hospitalized patients, futility analysis was passed, risk of death for mechanical ventilation was reduced by CASI-IM in seronegative patients hospitalized with COVID-19 and the low flow on the low oxygen supply. Consistent with previous findings in ambulatory patients, and serostatin was a strong predictor of poor clinical outcomes and treatment benefit. CASI-IM reduced viral loads in seronegative patients, and CASI-IM was generally well tolerated, and there is a largest data sets are needed to confirm these initial findings. And data from the recovery pending, and we can see in the next slide, and these are the very good data also studied in the recovery trial. And this is the world's largest randomized trial of potential COVID-19 treatments. This is a phase 3 open-label adaptive trial designed to multiple randomization and treatment arms with various treatments that have been tested to date, and additional treatments may be added as the study progresses. And they enroll hospitalized patients with suspect or confirmed COVID-19, and they include also CASI-IM 8-gram IV treatment arm with more than 4,000 patients recruited into this arm. And this is another nice study in which we have the interim analysis, in which we have the CASI-IM for post-exposure prophylaxis. And in this case, the subcutaneous administration has been used in asymptomatic household contacts in adult and child and living with SARS-CoV-2, living with an index patients with the SARS-CoV-2 diagnosis. And the primary endpoint was RT-PCR confirmed SARS-CoV-2, and then obviously the safety. And there was a cohort A PCR negative and the cohort B PCR positive, and the patient were randomized to receive 1:1 CASI-IM or placebo. And there was a remarkably reduced risk of infection and symptomatic disease in the household contact, with the 4.4 with a 50% reduction and the 100% reduction in the symptomatic disease. So very interesting data for the post-exposure prophylaxis, and these are the baseline characteristic of the patient, very young patients with also low BMI, and both were very well tolerated with no expected safety signal. And the summary of the interim analysis that are regarding the post-exposure prophylaxis, CASI-IM demonstrate a remarkable 100% prevention of COVID-19 symptoms when given prophylaxically to household contact after exposure to a symptomatic case. And the CASI-IM result in a 50% reduction in infections. One infection occurred, viral load remained very low, and the infection did not last longer than 1 week. CASI-IM demonstrated efficacy when administered via a convenient low-dose subcutaneous route, and the following positive data in the ambulatory and hospitalized patients. CASI-IM has demonstrated clinical benefit in an additional setting in COVID-19. Based on this data, CASI-IM may help to prevent infections in individuals who need immediate protection following exposure. So then, who is eligible for treatment? So who can be treated with the cocktail of monoclonal antibodies? The clinical trial results from the study 2067 show that these are the potential candidate for receiving the monoclonal antibodies. Ambulatory adults with mild to moderate COVID-19 with an age more or equal than 18 years old, positive for SARS-CoV-2, and less than 7 days after symptom onset. And the greater benefit is in patients with more than one risk factor for severe disease, like more than 50 years old, BMI higher than 30, and CV disease, like cardiovascular disease, like hypertension, metabolic disease, for example, diabetes, lung disease, like asthma, chronic liver disease, chronic kidney disease, and immunosuppressed. Better efficacy seems seen in patients with higher baseline viral load. As I mentioned at the beginning, higher is the viral load, higher is the benefit in using the cocktail, and there was better efficacy seen in seronegative patients. So the target patient population in the ambulatory setting, these are the regulatory assessment by the EMA, and the EMA confirmed that the patient that should be treated with this cocktail were patients with confirmed COVID-19, adult and pediatric patients with more than 12 years old, and patients who do not require supplemental oxygen and high risk of progression to severe disease and or hospitalization based on the presence of more than one of the following risk factor, equal or more than one risk factor, the one that I mentioned before, that are again underlined in the EMA scientific opinion. The approval by IFA, that is the Italian agency, has been approved for not hospitalized patients for COVID, in the ambulatory patient with mild to moderate COVID-19, this is the Italian Agency of Drugs, positive for SARS-CoV-2, and we can include patients if they have symptoms for less or equal than 10 days, and then at least one of the following risk factors similar to the one reported by the EMA agency. What do we know about real-world experiences with the cocktail of CASI-IM? So there is this interesting experience that is an early experience that has been published in Transplantation, that is a solid organ transplant recipient, and this is an early experience, to describe the early experience with the CASI-IM in 25 solid organ transplant recipients, 17 kidney, 2 liver, 3 heart, 2 heart kidney, with the median days of symptoms of 2.5 days. And there were multiple other risk factors for progression, like the age, the diabetes, and the kidney disease, and the vascular disease. And the data are none of the patients required supplemental oxygen and or hospitalization from COVID-19. And the only clinical complication observed was secondary bacterial pneumonia when patient which was successfully treated with a secondary course of antibiotic therapy. So our experience, and now it's my pleasure to present for the first time to my dear Indian colleagues, our experience in Genova, in Liguria region, that is this region you can see very well. This is my region. This is one of the wonderful landscape of the Liguria. This is an observational multi-center retrospective cohort study from March 2021 to April 21, performed to investigate the relationship between the time of infusion, early, less or equal than 5 days from symptom onset, versus late, more than 5 days, and the need for any supplemental oxygen or hospitalization. There were 3 major tertiary care hospitals of Liguria: San Martino Hospital, my hospital in Genova, Sant'Andrea Hospital here in Spezia, close to Toscana, and Sanremo Hospital here, close to France, to the border with France, to Monte Carlo, to Monaco. So these are the inclusion criteria were non-hospitalized adults with age more than 18 years old patients, confirm COVID-19 by polymerase chain reaction at the initial onset of signs and symptoms attributable to COVID-19 for less or equal than 10 days prior to the day of the infusion, and then mild or moderate illness at the time of the infusion, at least one characteristic of or underlying medical condition associated with an increased risk of severe illness from COVID-19. Hospitalized patients were excluded from the present study unless they had been hospitalized for reason other than COVID-19, for example, elective surgical procedure, or otherwise meet all inclusion criteria. So these are the data, and the data include 127 patients treated with the combination of monoclonal antibodies, and these are the underlying diseases: hypertension, cardiovascular disease, obesity, chronic obstructive lung disease, cerebrovascular disease, diabetes, secondary immunodeficiency, and chronic kidney disease. And the Charlson comorbidity index show in the McCabe scale show 85 in non-fatal, 11% ultimately fatal, and 4 in rapidly fatal. So the data that are here, this is the comparison between early use within 5 days versus late use after 5 days. And this is the comparison of the two characteristics. And you can see that the Charlson comorbidity index was higher in the early phase compared to the late. And there were more patients with the ultimately fatal McCabe scale in the early phase, and also rapidly fatal compared to the to the late phase. And then also the fever was higher in patients with after 5 days than in the other population. So these were the main difference. But the data are really interesting for the clinical outcome. And when we look at the clinical outcome, hospital admission related to COVID-19 was 22% in the late use of monoclonal antibodies compared to 4.5 in early use. And also the supplemental oxygen was present in 26.5 compared to 86%. And the overall mortality was not different, and there was higher just for number, because you remember there were 4 fatal for the McCabe scale. So our study add to other understanding of the benefit of monoclonal antibodies for COVID-19 by demonstrating that earlier intervention enhance treatment efficacy. Is very important, in my opinion, to start the treatment within 5 days, or probably within 3 days after the symptom onset. So in summary, what can we say about monoclonal antibodies? The CASI-IM cocktail is very active against COVID-19 with initial promising data across various patient populations. So neutralizing antibodies are an important therapeutic modality to fight COVID-19 at various stages of the disease. CASI-IM is a potent cocktail of 2 neutralizing antibodies against SARS-CoV-2 virus, reducing risk of emergence of resistance. The cocktail has been shown to retain its activity against the UK and South Africa variants of the virus. CASI-IM show initial viral and clinical efficacy in patient populations in various disease stages, and for post-exposure prophylaxis. Final data readout of 3 clinical trials are expected in the Q1, Q2 of 2021. So we are looking for the final data. Treatment of ambulatory patients has been endorsed by the European Union and by the US, and by a positive scientific opinion in Europe. For a successful CASI-IM treatment of ambulatory patients, the patient journey needs to incorporate physician assessment and infrastructure for administration of an IV drug. So I think this is my last slide, and thank you very
Vaishali, should we continue?
Yes, sir.
Yeah.
Yes.
So thank you, Dr. Bassetti. And I think Dr. Bassetti has joined us also now after his recording. So I think that sets the stage for a very comprehensive session. Dr. Bassetti, just in case you missed the initial part, we started off with the introduction. We've got panelists who are both infectious disease physicians times two, a critical care physician and a pulmonologist, in addition to me, who's also a pulmonary and critical care physician. So I think with this excellent background, we'll start with a bunch of questions. Can I just share my screen, Vaishali?
Sir. Yes, sir.
Yeah. So these are the panelists again, Dr. Bassetti, and you'll be interacting with them. So the interesting part here is that Dr. Bassetti presented everything from the role to the trials to what was one of the most interesting things was the experience in his setup. And I think the first bunch of questions we will target is towards that. These questions as a background have been collated from queries all over the country when rollout meetings were held for this in the last few days, and collated by both CIPLA and we also put in our 2 cents worth. So we'll go over these questions and in the time we have, and then depending on the audience questions which are either covered in the talk or these questions or anything new, we'll take up further queries. Though the initial questions are geared up towards Bassetti, Dr. Bassetti, because he has both the knowledge and the experience of using the drug. I would urge any of my panelists to just feel free to add to any information which they may have encountered in the course of their reading. So Dr. Bassetti, I think the main question which is going to come up is that in India, we have 1.2 million people. We went through the pandemic at a speed and a rate unexpected, unanticipated, and quite horrific. And now there will be a whole bunch of people who will be looking at this. The issue is we were looking at your spectrum and we saw the number of diabetics and hypertensives, and we have tons of those. Diabetic started in the world of this stuff. So one of the questions which came up in the panels which were taken earlier is that who can be more...
Sorry, there is a very bad noise. It's very difficult for me to hear your voice. I don't know what happened.
I don't know where it's coming from. Vaishali, any idea? The tech team can tell us.
Like a noise from a street or road or something like that. Okay, better.
Fine, excellent. Okay, thank you for interrupting. Should I repeat the question or was it completely lost?
Yes, because I missed almost all.
Okay, fine. Okay, let's come back to brass tacks. You have put down whatever it took to get this drug on the ground and your experience with it. We also looked at your experience, which added more to what was there, the less than 5 days and the more than 5 days paradigm. The issue here is in a country of 1.3 billion, as this drug lands on the ground, we have a whole bunch of diabetics, hypertensives, all the comorbidities and combination comorbidities in addition to obesity. So it is important to understand, is there any signal in the literature and in your experience which can help people to decide who gets the drug? So over here, one of the questions which came up in the multiple panels held over the country is listed over here, that will laboratory parameters help to cone down the population who's going to get it? Well, laboratory, radiological, and biochemical. What is your opinion in this regard?
So personally, I believe that there are no specific biomarkers because we have to use, I think we should use this drug in an early phase of the disease without having any of these biomarkers available. So this drug should be used before having all the typical signs and symptoms of the disease. And I cannot suggest to look at the chest X-ray or the CT scan or the PCT or the CRP or the D-dimer, because these are in general parameters that are altered in a late phase, not in the early phase. So for having the drug useful for the patients, we have to use this drug without signs and symptoms of the progression of the disease. Because when we have this kind of biomarkers altered, is already too late for using monoclonal antibodies.
Dr. Bassetti, to push this point further, one is reminded of the initial days of remdesivir where the EUA came for every hospitalized patient. And 9 months down the line, we're using remdesivir for a very, very select population, if at all. So the same thing would probably be here. I mean, it's such a wide net which has been cast when we talk of any combination or all comorbidities. And it's going to be quite a challenge to think about this. Do you think this analogy works, that ultimately over time, between the data collected and the studies which are ongoing, we'll be able to further define a specific population rather than give it to all comers? We have to learn from history.
So in general, for our experience, the patients, the obese patients, are the one that when they develop symptoms in the worst way. So probably, I believe obese plus maybe a second or a third comorbidity represent one important setting. And obviously, all the immunosuppressed patients, I am referring to cancer patients, bone marrow and organ transplant patients, any type of other immunodeficiency like HIV with poor control or evidence of AIDS, but also prolonged use of steroids. So these are probably the typical patients in which there is an advantage in using these drugs.
Okay, so do you recommend, as part B of the question, our young patients, because we have had a whole onslaught of young demises and debility and morbidity in this pandemic. So again, some of these off-label, and I do understand that you may not have data, but looking at perspective, do you think expansion can happen to these patients also, or you would restrict it to patients with comorbidities only?
I prefer to restrict to patients with comorbidities and patients that can progress to severe disease. I mean, I am referring to elderly patients and to patients with comorbidities. Otherwise, it's going to be very difficult because when there is a pandemic dissemination of the disease, you have to treat almost all the patients. And obviously, this is not affordable, I mean, for the system, obviously.
Right. So a young obese person who comes despite the risk of disease, one would at this point hold back, is the message we are getting. Would any of the other panelists want to comment on this?
Ravi, I wanted to question Vasant here.
Yeah.
Thank you, Dr. Besidi, for that wonderful lecture, and been learning a lot from every time whenever I hear your lecture. So my question to the B part of the question is, it has been completely different from the Western world. What Dr. Ravi Mehta was trying to say is that we have the ICUs full of people between 25 and 40 years of age who are on ventilator, which does not had a gender also, males and females, even young females of 25 and 30 and 40, 35 have been on ventilator, and they have succumbed to this disease without having any comorbidities. So I think what Ravi Mehta wanted to ask you is that this population of India who has succumbed to the second wave and with very high mortality in this group, who do not have any comorbidities, would be, how do we go about these people?
So actually, I understand your point, and I think I can agree, but, again, is going to be part of your organization. I mean, actually the drug in my country is not approved in this kind of patients. And obviously for us, it's impossible to use, the only way is to use the drug off label. But maybe, I don't know, it's very difficult to say, because obviously if you have to use in young patients, you have to use almost in all the infected patients, because actually we don't have any risk factors, we don't have any type of stratification for knowing where to use and where not to use in young patients.
So I think we can understand the fact that the studies were done in the first wave and the earlier part of the second wave, and most of the target was on the high-risk population. That's understandable. So I think we'll leave this point as being an interesting point and go to the next part of the queries. Timing, Dr. Bassetti. And then you've touched on this partly, but I want to make a clear case on this and leave a clear message. the literature says 10 days. You have shown that 5-day paradigm over there. You see the question over there. What would you tell people to have the maximal benefit? When would you use it? And I think your data is partly justifying that. And the second part of it is again a question linked to the prior one. So I'm not going to push you on it. But the particular prototype, when fever persists more than 7 days, there is a lot of debate over here whether steroids are to be given or no. In such patients, before steroids, would an antiviral strategy like casirivimab and imdevimab be useful? Can you touch on these particular points together?
Okay, so I believe that for our experience, but I know that there are similar other experiences in other countries, the early administration of the monoclonal antibodies is strategic. So we have to say that probably the best time for ideally use monoclonal antibodies is within 5 days or within 72 hours after the beginning of the symptoms or after the positive swab. So this is, in my opinion, the best time. So, and we have to move for using monoclonal antibodies as early as we can, organizing a system in which the GP doctors can select the patients, and then obviously, at least for the IV formulation, but I know that in India you have also the subcutaneous form. I think the drug should be used also outside of the hospital. But in my opinion, it's very important to use the monoclonal antibodies within the first 5 days. So where the fever persists for more than 7 days, I think this is too late. Okay, so if I have a fever that persists for more than 7 days, and I have also a patient that is in supplemental oxygen, this is probably a target scenario that is not the best for monoclonal antibodies.
That's interesting. Now, to push this, and do bear with me as I push this point further, a lot of people get, in India, for example, a testing got delayed. So a lot of the disease was looked at from the RT-PCR date rather than the symptom date. The symptom date also being a little subjective and people may not remember. Is that something which is a little loose, or would you say that it's okay to give it in a little range over there? What would be your take on it? Where does the taper of the benefit happen that you would say not useful at all? Is that the 7-day window?
So 7 days is probably too late, in my opinion. So we have to try to do everything in order to include with these medication patients within 5 days. So, but then obviously you can eventually use even a day 7. But in any case, in my opinion, it's better to try to give this medication within 5 days.
Okay, any of the other panelists want to comment on this?
I think, Ravi, that's absolutely reasonable to sort of go up with the 5 days. Beyond 5 days, probably is going to be too late for any therapy which has shown to be beneficial within the time. I think in COVID, everything is about timing. And if you time this correctly, you're probably going to get the best benefit of it. And we should probably just promote it in the way that it should be taken within the first 3 to 5 days.
I think 10 days taken with a pinch of salt, which is the label, 5 days, and push towards symptom onset accurately assessed, and not the RT-PCR, which is often happening and too often happening. Okay,
it's important, in my opinion, to establish relationship between the community and the hospital in order to have a link, because obviously monoclonal antibodies should be prescribed by hospital doctors. But it is important to have a very good relationship with the GPs, I mean, with the doctors in the community.
So,
Dr. Bessity, Ravi, I wanted to make a point on the previous question.
Sure,
Dr. Bessity, I wanted to ask you, suppose if some patient comes on day 7, and if you do the antibody, and if the antibody is negative, then would it be judicious to give this monoclonal antibody since the patient has not formed antibody?
So I think that in any case, even at day 7, you can prescribe it, okay? We have prescribed in many cases, even day 7, day 8, day 9, and we have observed an advantage
over no treatment. But to get the best advantage, you have to prescribe earlier. So this is, you know, our experience. Obviously, day 7 is fine, okay? Day 7 is not day 11, okay? But my personal recommendation for the feeling using in more than 300 patients, actually in Genova, is to be, I mean, to have the prescription in the first 5 days.
Right. We get the feeling, Dr. Bassetti, that over time we'll have 3 to 5, more than 5, 7. We'll have phenotypes of this subsets over time. But for the preliminary discussion, understanding, I think this is the message given out. Let's get to safety and exclusion, which also came up. And you can see the questions out there. Pregnant women, a provocative question on the subcutaneous administration leading to blisters, angioedema, and of course the eternal thing. Second episode of COVID infection, can this be given again?
So, could you please, because I miss, you know, because I see the slide and I say something different. You know, could you please repeat?
So yeah, so safety and exclusions. First is pregnant women. Second is safety from the point of subcutaneous administration from the point of view of local reactions. Third is the eternal thing of angioedema because of a parental antibody. And then, of course, comes the fact that safety point of view, if you have a second COVID infection where we expect antibodies, can we give this antibody in addition to the endogenous antibodies a patient is expected to have?
Okay, so for the first cocktail, pregnant women were excluded, at least in my country, from the administration of these drugs. You can eventually use in an off-label way, but I believe, you know, I don't know how is the label in India, but in Italy, pregnant women were excluded. The administration, the subcutaneous administration has not been used in my experience. However, the data that I present today were not different in terms of side effects compared to the IV formulation. And angioedema, I show you the data regarding the clinical experience, was not one of the main side effect report. And regarding the last question, the drugs work not only for seronegative, but even for seropositive. So maybe if there is a patient that experiences a second episode of COVID-19, I think this drug can be given again.
Okay, so for the benefit of the audience, the subcutaneous administration has not been approved in many parts of the world as an emergency measure because of the rip-roaring pandemic. The director DGCI of India has approved subcutaneous administration, so it's a little new to everybody, and we'll have to see how the rollout happens in our country also. One of the most interesting parts, Dr. Bassetti, is how to reconcile active COVID with this vaccination part of it. We have unusual phenomena in India where our vaccination centers are at this point, by and large, combined with the hospitals, though of course that is changing right now. So there is a fear of one shot, second shot, not getting the shot. We are privy to 2 vaccines, if not a third one coming on the ground, and people are getting peri-vaccination COVID also. But in the background of this, there is a whole bunch of questions which came out on this. If you can see my slide, I'll go through each one of these. First question was that, is there any concern for giving the cocktail to patients who get infected at more than 2 weeks post-vaccination, as by this time the body has started producing endogenous antibodies?
So in any case, I believe that if you have a patient that has been vaccinated and developed COVID, you cannot exclude that the patient was in incubation period eventually during the time after the vaccination. So I have a patient, we have several patients that got infected during the vaccination or the day after the vaccination. So I believe that if you have a disease, I think in any cases you can have a benefit of add more antibodies. So this means that if the patient developed the symptoms of the disease, was because the antibodies were probably not enough. And I mean, if we are in a certain type of patients, probably there is a role for monoclonal antibodies.
At the same time, thinking of whom to give it to, if we're sitting with limited stock, because I feel 2-3 weeks from now, we'll having another webinar where we say our stocks are down and let us figure out whom to give it to. In such a situation, would you say these people come low on the list of trying to give the drug, even if they're 65 with diabetes and a BMI of 30?
Yes.
Okay. The other question was, after proper vaccination, say, one or maybe both doses, at that point, do we expect that again, similar to the first one, is it something which should be coming as a very loose indication rather than something which can be given liberally, even with the age more than 60 and comorbidity spectrum?
I believe that, again, that if the patient has the infection, even if was vaccinated with 2 doses, was because his immune system was not able to control the disease. So, and I believe that in any case, it's important to give monoclonal antibodies.
Right. So now you must be following the vaccine literature all over the world. Covaxin is our local vaccine. Not sure how much you've been following that. Covishield is the AstraZeneca Oxford product we have here, and Sputnik is Russian. Would you think that these vaccines, if you take both doses of these, is there any difference in the antibody production, or the thinking would be the same? It's not worked, boost with the product and take it from there.
No, because it's a completely different way of working, the monoclonal antibodies in respect to the vaccine. So the vaccine work in different manner compared to the monoclonal antibodies. So monoclonal antibodies is the combination of human antibodies plus mice antibodies. And I believe that in any case, again, I believe that these drugs will be very useful even after the mass vaccination. So, and I continue to believe that there is a role for these drugs, even in patients that has been vaccinated with the 2 doses. So regarding the last question, that is the 3 months after the administration, I agree. However, actually, the recommendation is to use this drug 3 months after the administration of the first, to give the vaccination at least 3 months after the administration of the antibody cocktail, but maybe would be fine even to give earlier.
Right. And can I persist on this particular question? India is a country of antibody tests. Everybody is trying to quantify the antibody like the stock market. More antibody, more protection. Does that have any meaning at all in trying to pick and choose which patient will get this this cocktail?
Sorry,
India has a bunch of antibody tests. Every center is offering anywhere from 10 euros upwards, and many people are getting antibodies to quantify it. More antibody, the better. General antibodies, anti-spike antibodies. Would it make any sense at all to look at that antibody, or one should just keep the science to one side?
I think there is no, actually we don't have any data that support the fact that if you have more antibodies or if you have less antibodies, you have a better response against the virus. There are no data about that. So measuring the monoclonal, the antibodies, even in Italy, there are a lot of people that are doing that. In my opinion, does not have any sense after the vaccination. It's probably interesting for doing that before the vaccination, for knowing if the patient was infected before, if the patient is seropositive or seronegative, and probably is fine to perform serology only in certain type of subjects. I mean, immunosuppressed patients with cancer, in which we expect a lower response to the vaccine. But doing the serology in the whole population is absolutely not useful.
Right.
Confound our ideas.
Okay, so it seems to be a very pure science, I think, that it's a boost over here, irrespective of what numbers you have, what vaccine you have, and when you have. Would my co-panelists want to say something? Subra, you have any comments on this part of it? We've tried to dissect the science on both sides of the vaccine.
I think the concern is going to be that if this can be considered even for patients who've had a vaccine, I think it's going to increase the pool of people who become eligible for the monoclonal antibody. And there's no way we can get enough of it to give it to everybody. So in that setting, should we just prioritize people who are unvaccinated over people who are vaccinated?
Right. So I think lovely questions. Like I said, this is just the opening part of it. Reminds me entirely of the remdesivir story. I'm sure, a few weeks to months, because I think the maximum rollout of this, depending on the amount of drug, will happen in our country. US is seeing the end of the pandemic. I think Dr. Bessetti, you guys are lucky too. We are still going strong and rip-roaring, and we are left with this eternal thing called fear and worry. And I think we're going to see a lot of views. And if we can collect data, I think a lot of these questions may get answered before we run out of stock. Okay, let's get on to more understanding. Now, can this be given along with other antiviral strategies? We have the 7-day window. Remdesivir is also going through its own data. We have plenty of these in our country, Dr. Bessetti. I'm sure you're going to blow all of them off. We have ivermectin, we have favipiravir, we have interferons, which I'm going to ask my local faculty. But at least for a drug like remdesivir, do you think there's any issue with combination, assuming they fall in the subset you mentioned who are eligible?
So we, the criteria for using monoclonal antibodies, at least in my country, are opposite of the criteria for using antivirals. I have mentioned remdesivir. So in Italy, remdesivir is authorized to be used only in patients with supplemental oxygen. Only in this setting you can use remdesivir. So for using monoclonal antibodies, you cannot use monoclonal antibodies in patients with supplemental oxygen. So if you can combine, but there are actually no reason, because we recommend to use monoclonal antibodies in the early phase of the disease before of the more serious symptoms. So if I combine monoclonal antibodies with an antiviral, is because there is no role for monoclonal antibodies. So eventually you can add an antiviral later if the patient develop more serious symptoms, like you give the patient on day 3 after the beginning of the symptoms. So the patient on day 6 develop pneumonia unless of the monoclonal antibodies and need supplemental oxygen, okay, you can prescribe remdesivir or any other type of antiviral medication.
So again, the point comes out that tandem therapy is okay. Does tandem therapy actually mean that the antibody is not worked and they're going on to oxygen, so they fall in the category which is going on to hospitalization?
Yes, actually we don't have any data that suggests that antiviral should not be used. I mean, there is no data that one compete with the other. So if you want, you can eventually prescribe also an antiviral. My concern is that do the patient need monoclonal antibodies plus antivirals? Maybe not.
Right, but the subset which actually goes on to reach the hospital with oxygen who qualifies for the antiviral, would one take it as a clear failure of the monoclonal antibody?
It's not a failure. The monoclonal antibodies, the main objective of the monoclonal antibodies is to reduce the hospitalization and to reduce the death, okay? And at the end, and to reduce also the length of hospital stay. So I don't consider a failure. I consider a situation in which maybe the monoclonal antibodies reduce the severity of the disease in any case, because we cannot know what happened in the same patient without monoclonal antibodies. Maybe with monoclonal antibodies, you need 2 liters of oxygen. Without monoclonal antibodies, the same patient should be intubated. So I believe, is obviously case by case, and there is no, I think we cannot consider a failure if the patient needs a supplemental oxygen.
So reading between the lines, there are situations where the antibody is given. I get hospitalized with oxygen, but I make it through, and it could be regarded as one endpoint which got met, and the other endpoint, the endpoint of avoiding death got met, but hospitalization not got met. Is that something one can read between the data and still go on?
I missed you for a while because the connection was not stable. So could you please repeat?
Yeah, we took this endpoint of reduced hospitalization and death as one continuum. Now, obviously, an interesting point which you have brought up is that if hospitalization comes with a lower severity of disease and avoids
Yes.
demise, that also would be an endpoint which is desirable, and it would fall under the gamut of the antibody may have worked. Are we to understand that?
Yes, exactly. Was one of the endpoint in people that has been treated with the monoclonal antibodies. The course of the disease was less severe compared to the patients without treatment with the monoclonal antibodies.
Dr. Ravi, I wanted to ask a question in the previous question what you had.
Please do.
So Dr. Bassity, so since I know in your country, remdesivir is only licensed for people who are hospitalized with oxygen therapy. But according to us, I think, don't you think it is late to give remdesivir for people, since it's an antiviral drug, just like a monoclonal antibody, which is to be given early. So your remdesivir, just like your oseltamivir in H1N1, you have to give it in first 48 to 72 hours. Similarly, the role of remdesivir would be also to give early. And so I want to know, is there any head-to-head trial where remdesivir given as an antiviral drug early within 72 hours, which should be given, and not in same way, remdesivir has got no role after 7 days. So whether is there any head-to-head trial where monoclonal antibody versus remdesivir, because remdesivir may also work the similar way as monoclonal antibody.
Yes, the only problem is that remdesivir demonstrate to have a benefit in the New England Journal of Medicine paper with the first name Bagel was able to reduce the length of the duration of the disease only in patients with supplemental oxygen, not in patients without supplemental oxygen. So if you have a patient in the first 3 days of treatment with supplemental oxygen, no problem of using remdesivir instead of monoclonal antibodies. But in the first stage of the disease that doesn't need any supplemental oxygen, there is no role. There are no data to support the use of remdesivir.
Any other questions?
So another question was, Ravi, one more. Ravi, another question was, just like monoclonal antibody is being manufactured right from the people who have suffered from COVID and they have high antibody titers. So what is your comment on giving a plasma where people have suffered from COVID and have a very high nucleocapsid antibody? If you give a plasma which is rich in nucleocapsid antibody in a suffered from COVID patient, would that be equivalent, and why it has failed? So if it is given in first 5 days, possibly would it do the same benefit what a monoclonal antibody is doing right now?
Theoretically, yes, but you have to demonstrate with a clinical trial. Otherwise, is an opinion that I respect, but actually we don't have data similar for plasma that we have for monoclonal antibodies. So maybe in theory, yes, because the way of working is exactly very similar. But, you know, I don't have any data.
Right. So, Dr. Bassett, if we are going through all the preprints, it's very interesting how they're talking of convalescent plasma not working against variants, even though it's coming from COVID recovery people. The fact is that you may recover from one infection and you may have a variant which the antibodies as a combination may work. And the third is the titrated dose, which is shown in studies which you cannot get in plasma unless you measure it. All these points are coming out as differentiating factors from a plasma with uncertain dose versus an antibody with a studied dose. Am I right in making some of these statements?
So, you know, I prefer not to talk about plasma because in Italy, we decide to have a recommendation against the use of plasma. So we have a national recommendation that plasma should be avoided, even the hyperimmune one for treating patients with COVID. So if you want to, if you decide to use plasma, you have to have a special authorization from your ethics committee and from the manager of the hospital. There is actually in my country no role for plasma.
Right. So now just a background for the next lot of questions. You know, India has been reeling under the variants over here. We had multiple variants from many parts of the country, right? And 16172 with the, you know, the RBD things over there mentioned over there have been very concerning. Considering that the studies were done all in the US, and we have this variant which is spread to our country, it will include a drug which is equal to 4 times the per capita income of any person. Where would you stand with these? Including people want to know if I have mild disease and I'm diabetic, will this investment work for variants that are being ravaging this country?
So I know only the data that has been published, and the monoclonal antibody is the variant were circulating in US at that time, the British one, the Brazilian, the South African. So maybe the monoclonal antibodies is active also against the Indian variant. So probably, no doubt. But I think we have to prove some data, because actually I don't have a personal data supporting the use for Indian variant. If you have any data, please share with me. I don't know. I never treat any Indian variant in my hospital. I have used it in South Africa, Brazil, variant, and the monoclonal antibody work.
So Regeneron on its website, and there are preprints in medRxiv which are actually talking of efficacy against the variant also of the combination. Clearly, there are now preprints telling us, preprints of course with a pinch of salt, that bavdegalutamide by itself is not working against the variant. That has been shown as a preprint. But a similar preprints also coming to show that the combination of CAS and IM, as you put it, is actually working very well for 1617.2. That's coming as a very interesting thing to bring up a point, since plasma is still a small part of what is done here and going away, that plasma is unregulated while this has a regulated dose. And so that may work against this variant, and it's there on Regeneron's website. I think the data will follow as these preprints. This is what I have read, and I would love my panelists to add to it or anything. Anybody? Okay, fine. Another question which came up, Dr. Bassetti, in the trials is, what is the percentage of primary non-responders in the phase 3 study? So the antibody cocktail did not touch at all and are completely not candidates for this cocktail.
So, I show you the data in the studies. I don't know. I never had this question. Sorry about that. I don't know the percentage of primary non-responders. We don't know if the patient progressed with the disease because of the other situations, other than the fact that the patient didn't respond to monoclonal antibody.
Right. Okay. And I think demographics and patient profile had come, but you covered that in your talk, where the indications are, what is there, and in your particular study experience from your part of the world also. So I think that we can skip because it's already been covered. I now come to the local issue.
Can be extrapolate from the presentation.
Right. Thank you so much. So now the most important is local issues. When any drug gets launched over here, it's always a challenge because of multiple issues. On one side, we see a huge challenge because of the massive numbers, the large number population which qualifies. At the same time, we know that we'll have limited stocks. It is expensive because it's, like I said, around 3 times the per capita income of the country. And so I would like to pull in my Indian panelists over here. Where do you see monoclonal antibodies being used in the Indian context? Do you think that this is an antiviral agent of great promise, as we've gone through 1 year and pretty much blown off most of the other antivirals? And in the same note, where would you position it in your estimation at this point, which I know could change 4 weeks from now? Dr. Bassetti, at the end of it, please give your editorial comments. This is because there's no data on this and none of the Indians have used it. But my panelists are very astute and they've been since April on the forefront. So I would like to ask them. Dr. Subramaniam?
So I think there is obviously a self-selected population that we have identified in the, rather selected population that we have identified. Those who are high risk and those who haven't had the vaccine would probably be my first guess. I would also include people who are transplant, people who have oncological issues, people who are immunosuppressives. I'm even thinking of pregnancy, but then again, it's off-label, I understand that. But people who have not had the opportunity to get the vaccine, or people in whom the vaccine may not have as much benefit as oncology and rheumatological indications and things like that, would automatically be candidates. Again, there is really no limitation on who we can include in it. I think it's more exclusions rather than inclusions based on what we see. But yes, I think the net is too wide.
Right, Dr. Nagvekar, your thoughts? I'm sure some interesting thoughts when your patients in Bombay approach you and say, my brother died of it, I'm 45, but my BMI is 30, and I have 50,000 rupees, 60,000 rupees. Please give me this, and why are you stopping me from taking this, despite whatever Dr. Bassetti and the literature says?
So I am very clear about this, that if any patient, just like Dr. Bassetti and the data which says that any patient who's got even high risk factors and having fever going on, and those patients should be definitely offered this, as well as all patients with chronic liver disease, renal failure, transplant population. I think the huge, just like Subra said, it's more of inclusion than the exclusion criteria. But I would also include, just because our population was completely different, so I would include all those people who do not have risk factors, younger population beyond 72 hours, if they're running more than 101 fever, because that is a viremic phase. So I would possibly include that if the advisory permits to do that, because beyond 72 hours, if somebody is running 101, 102 fever, and even if they don't have a risk factor, why should not they be given this monoclonal antibody?
Right. So I think it's ripe for a study. I think tons of data can come out if we can regiment our practice compared to the literature, because I think this is just a preview which we have from the worldwide literature to use in our country when we still have the pandemic going on. Rahul and Rajesh, if you could enlighten the cost issue. We've gone through a country which was so debilitated for cost. And at this point, the cost of COVID morbidity, hospitalization, and of course, demise is immeasurable. What do you think at the 60,000 rupee? And for Dr. Bassetti's benefit, I think that's around 800 euros. 800 euros, single shot, 60,000 rupees. What do you think is going to be the penetration, limitations, and how do you think it's going to impact practice?
I think that, Ravi, I think that the cost is, of course, going to be a lot of, it's going to have some factor. In the sense that I think the drugs which have been marketed is for two I think patients. So I don't know whether it is available for an individual patient or it's to be taken in up to doses of 2 only. So if you factor in 2 doses, then of course cost would be a factor, because it would be something like 1.2 lakhs rupees of this thing. And again, it will be an issue because it's quite costly, and it has to be covered by also medical insurance. So I don't know whether it will be of course covered by eventually by medical insurance, because here we are not going to admit the patient. So that is of course one issue. And another thing is that yes, for I think affordability, if you say, and if you compare the cost of hospitalization that happens in these patients, then of course this of course would be what we call a cost effective, I think, of measure. That's what my point is.
Rahul, to add to your thinking, the recent latest preprint shared by everybody was that it came 4.6 to 1.3. The risk came down to 4.6% to 1.3% was the reduction in hospitalization and demise. How would you factor that into the cost? And you live in Mumbai. I mean, you do ECMOs regularly. Your take on this?
Look, Ravi, this cost factor is going to be actually, if you include the entire population of the country, majority of the people will find this to be out of their reach. So we are looking at a population which is going to come to hospital like yours and mine, where 60,000 rupees may probably be affordable, because they are going to compare that with the hospitalization, which is going to be far more than 60,000 rupees. So it's going to be limited to a population which is able to afford it. At the moment, insurance, I think, is not going to be probably reimbursing the cost unless the regulatory changes are made, or unless you are actually going to get around the thing by admitting the patient there for 24 hours and then discharging them. I don't know, the Indian jugaad will have to work out here to sort of get the regulatory regulations out of the way. But I firmly believe that there is a role for this in patients who are high risk, who have got 3 to 5 days of symptoms, and in whom you can actually avoid admission by giving this drug. I think that's where it makes sense. It does not make sense in inappropriate timing, wrong indications, using it by extending it beyond 7 to 10 days. I think that's actually a dangerous signal to send. We should be, as clinicians, be able to shoulder the responsibility and say that we will only use it for 3 to 4 days of onset of symptoms. The moment we start using it and giving it outside that box, people will start abusing. You know, the limits get stretched and stretched and stretched. Remdesivir was given on 20th day also by many people, for 10 days as well for the course. So it's going to be the same thing here.
So Dr. Bassetti, bear with us as we discuss our local issues, because as we say, we're 20 Italy's at this point. So again, the cost part of it, diaspora, people from all over the world were saying they're willing to sponsor one patient when the drug comes here. Plus, all of us are part of some state committee or the other where the government tries to fund these drugs, tocilizumab included, which is equally expensive. But do you think that will become a facilitatory thing, that money will come from somewhere and the expansion of the use may happen?
So in any case, for the experience we have in Italy, the average length of stay any COVID-19 in the first wave was 12 days. In a second wave was 8 days. So in Italy, 1 day of hospitalization without requiring mechanical ventilation costs around 500. So this means that the average cost for a patient in a standard ward was around between 5,000 to 10,000 euros. The cost of one vial of monoclonal antibodies is around 2,000 euros. So if I can prevent one hospitalization, as demonstrated in the study, I think at the end is cost effective, particularly when there are so many hospitalizations at the same time. It's not only an issue of cost, but it's obviously an issue of the social life and the public health.
Right. So I think a local issue of economics, affordability, funding, and ultimately the life saved will be something which will stand out. Subra, already Rahul touched on the point 3 over here. Where who do you think should hold on to the drug? Let's face it, we're going to run out of this very fast. Subra and Basant to follow. How should the drug rollout happen? Should it be given to all and sundry, or should it be regulated, which is something we have not done easily unless we went through shortage?
Well, you answered the question yourself. It's not going to be possible. The point is, as long as there is DCGI approval for an expanded indication, it's going to happen. Like you mentioned, even outside of context, it is going to happen. So let's just hope that it at least goes to the people who need it. I think the one people who can probably get out of it is probably those who are already vaccinated, because the risk to them is astronomically low. But my worry is there is not going to be any gatekeeper here.
Right. Vasant, Mumbai?
I agree with you. I agree with Subra that, I think we'll have to have an expansion of the inclusion criteria. Of course, everything is almost 80% is already included. So, but that small population, what you and me were discussing, I think they may be included, and I think that should be, that is what we require. And I agree with Subra about this.
Oh, Vasant, I would actually say there has to be a decrease in the inclusion criteria. You did not expand it. You need to make it more strict and stringent. I think if you expand it, it's gone. It's going to basically run out.
Yeah, I'm talking about those younger population who your ICU and my ICU are flooded with ventilators, where people are between 20 and 40 years of age, and who have been, I'm talking about those people. If those people would have received monoclonal antibodies, if they were running fever beyond 72 hours, I think the ICUs would have been, the beds wouldn't have been occupied for much. So I'm talking about those population.
So Vasant is bringing up the angst we all went through. And if the drug had been available, say 4 weeks ago, what would have happened? A different story by itself. Let's move on. We have around 10 minutes more. Rahul, interferon, we have to put that into perspective for everybody. Interferon recently approved as a EUA also as an antiviral strategy. Your take on that vis-a-vis the cocktail?
Look, the last magic drug I used was in the month of August. I have actually been a very, very conservative doctor. So interferon, it's been sent to me by Maharashtra government. I have not used it yet. And I don't know how much data is there actually to substantiate its use in a larger scale. I would probably use something which is going to avoid an admission rather than actually something which is being given at an early stage as an antiviral therapy. I would much rather stick to the data of remdesivir and stick to it. I really don't know how the interferon therapy is going to fit into the whole puzzle of this COVID-19 antivirals.
Subra, can you add to it? Infectious disease perspective?
I agree.
Okay, that's an easy response. Rajesh, this oxygen therapy, though the guidelines say for this drug that patients are on prior oxygen therapy will not qualify. Obviously, there's a whole bunch of people with lung disease sitting out there, which you follow also. How would you factor this in?
So I think, Ravi, that patients on chronic oxygen therapy actually were excluded from these phase 3 trials of ambulatory patients, and I think it has not come under the recommendation. But I don't know why we should not use this drug for patients. For example, there is a patient of COPD who's there on home oxygen therapy, and he has COVID. So he would be basically a risky patient to treat if he has some problem. For example, also with further this kind of ventilation. So I think why we should not give this to patient. I think it's only because that we only included ambulatory patients in of course phase 3, and hence patients with chronic oxygen therapy were not included. But I think going down further, I think there is no reason that we should include these patients. And I would like to ask this question also to Dr. Mate, in fact, that why we can't include these patients.
Dr. Bassetti, would you like to tell us why chronic oxygen patients should not qualify?
No. Chronic oxygen should be qualified for treatment. So there is a problem only for patients that need supplemental oxygen. So if you have a patient in chronic oxygen, like a chronic obstructive pulmonary disease that got infected, you can use monoclonal antibodies.
But I think in the fact sheet that was
we have
given
several cases in which we have used monoclonal antibodies in patients with chronic oxygen.
Dr. Bassetti, they pointed out on the fact sheet you can't use it. They specifically put it in exclusion criteria. And we were wondering why, and we're hoping you can throw some light on that. It's an exclusion criteria.
Is in your exclusion criteria in India?
No. It's exclusion criteria given, I think, in the
fact sheet. In the fact sheet of the European Union that was they have specifically said.
In our experience, so, okay, if I have a patient that is in chronic oxygen because of a lung disease, an underlying lung disease is absolutely not an exclusion criteria.
In fact, the Indian literature
I have at least 50 patients treated with monoclonal antibodies with chronic oxygen.
Okay, that's interesting. So we leave this point alone for now. Let's come to Rahul. Anything? I think we've answered this question, but do you think the patients who get these antibodies and they come to the ICU, it's going to impact anything we do at all, or not really?
I hope they don't come to us at all. That's the whole purpose of giving it. I think you and me should stay out of this. I mean, you can. I should stay out of this business, actually.
1.3% will still come to you as per the preprint that goes to publication.
Yeah.
More local settings, the setting of administration. People are going to get very provocative now. Hospital in a regimented setup like Dr. Bassetti's, home settings, ambulatory settings, mobile settings. What is the take on these things over here? What do you think is going to happen in our country over here? Subra?
I would be very scared to give it outside of a hospital setting, at least in the beginning. I think we need to have enough experience of knowing how to do it. And because it's still a plasma product, it's still a human, antibody, I think there is theoretically a risk of allergic reactions. So no, I would not recommend it outside of a medical care setting where you have at least a crash cart.
Basan?
Yeah, I agree with Subra. At the most, we would give it in the triage area where, all medical, and give in the triage area and then send the patient home, wait for 2 to 4 hours and send home. But the problem is going to be once you have the Mediclaim, approving the cost, there will be 24 hours admission. But I think the best would be to give in the triage, give the shot, wait for 2 hours and then send the patient.
Rahul, we've had mobile ICUs, we've got mobile vans in vaccination. We gave it in the hospitals and we're going to the community. Do you see that we're going to partially equip people to handle some complications and give it in the community?
I don't think so. Any of that is going to happen. I think, in fact, I would tell you the contrary what will happen. 99% of these patients will be admitted for a day or two. I can guarantee you on that. If somebody is paying 60,000 rupees, he's going to get admitted for a couple of days, at least in the initial part. And only then the confidence will come that you can actually send them home. So I really doubt any of the 0.7 and 8 is going to be there. 0.9 will be the maximum takers, I think. Mild disease with comorbidities who have got admitted and who are within the first 3 to 5 days, they will be the ones who will be receiving it.
So I think if it is really going to happen that way.
I'm very sorry, but I have to leave you because sorry, I have another meeting starting
Thank
in
you.
2 minutes.
Thank you, Dr. Bassett. I think if you can leave whenever you want, we're just going to finish in the next 2 minutes. Do you have any closure to make?
Ravi, I wanted to make one just, Dr. Bassett, sorry, I just wanted to ask you one question. What was your clinical experience of defervescence of fever the moment you had used this? Was it less than 24 hours or 48 hours in your clinical this thing?
Sorry, I missed a part. I'm sorry, I have a connection today. I don't know. So, could you please repeat?
I wanted to ask you, what was the defervescence of fever in your group of patients whom you treated after giving the monoclonal antibody? Was it 24 hours, 48 hours?
I don't have this data. You know, the majority of our patients didn't have also a fever. I think fever was present in less than 15% of the patient treated in early phase.
Right. So Dr. Bassetti, before we let you go and say thank you very much, would you give some final closing comments? You can see the cartoon out there. Is this drug a game changer, an add-on, or just one more drug which has come? Your final
for our experience was a game changer. You know, it changed a lot our practice and help a lot the hospitals because we treat 300 patients and I believe that at least 100% of them didn't reach the hospital, and this was good for us because we can take care of other patients.
Well, thank you very much. And I will ask my panelists to give any closing comments. Dr. Bassetti, please feel free if you have to go ahead. Otherwise, my panelists, can you just make one minute?
Thank you, ciao, bye.
Thank you so much. Pleasure.
Thank you.
So, I think this would be a game changer in the sense that we have got some drug which of course can be given when we contact the disease, but it's to be used judiciously. Otherwise, in a first country, of course, in a country like us, where of course guidelines are not that much followed, we may end up actually being out of the market very soon. In fact, so that would what be the caution, actually, just from my side that we had to use it only for actually mentioned indication and not just sort of rampant use, and that's my concern.
Right. Vasant?
So I'm very excited, especially for my solid organ transplant patients and patients who are on kidney and chronic liver disease and having a very high BMI index. I'm struggling with a 160 kg lady now. So, you know, something of those, I'm really excited for this job.
Lovely. Subra?
I think it was overdue, and I'm happy that we've got it now. I think the next few days are going to be critical in making sure that we use it the right way so that the right kind of messages go out and there can be mentoring of new centers that are coming up. But in the long run, I think this is going to be part of the solution, not a full solution by itself. We still have to focus on vaccination and all the other protective measures.
Excellent. Rahul?
I'll be very honest with you. No drug is a game changer. It cannot be a game changer. I am very honest and blunt about that. You have to add it on, use it as an add-on therapy, or maybe just one more therapy at the moment, and see how things go across. It cannot be a game changer in our population for a drug which, if steroids were a game changer, we have blundered it out. And right now we are crying with mucormycosis coming across the country. So we should not call it as a game changer. We should actually have very strict regulation of using it. Use it properly, make it a game changer. It has a potential to be a game changer, provided it can be given to the entire population.
In detraction and perspective lies a very interesting conclusion. So I will conclude with the last few statements. To conclude, I think basically this cocktail came to fame with Trump taking it literally a few months ago, has finally gone through a slew of data, made it to many guidelines as a strong recommendation flow with low quality evidence, has finally come to the Indian subcontinent as the pandemic is beginning, but still has a significant impact in our country. The science seems to be clear with the available data. Looking ahead, and I'll make some editorial comments on that. Looking ahead, I think it's too wide a net they have cast right now. I don't think it's going to work for us if we start throwing this out left, right, and center, and we will extrapolate it to every person who's 44, obese, and who we think is going to reach our ICUs and so on and so forth. So I think this initial science, just like the remdesivir science, will get tempered over time. We may have to identify subgroups, as my panelists said, including the vaccination subtype, and we'll have to figure out whom to give it to. I don't think history says that we have limited stocks. We give it to all and sundry, and then down the line, this becomes a webinar of historic importance as we try to have the eternal discussion on how to do COVID in resource setting. At the same time, I think that the use should be judicious. As pointed out, restricted use would be important out here to maintain the stocks because unlimited stocks are not going to come. Interestingly, cost, which is a game changer in our setup, it's actually the most game changer limiting aspect, is going to probably be less important out here as people will scramble and there'll be much more sponsorship coming. So I think with this rounded perspective, I would put this as my panelists have said, and to put Rahul's opinion into final context, is that we have something on the ground. It looks interesting. We have to figure out where it goes. This is the current science. Let's be more responsible than the other therapies of COVID-19. And God, we need something which works in this our country before we ever go through what we went through. So I think with this sort of putting everything together, the last of course thing I forgot is vaccination. Before vaccination, after vaccination, what to do, which vaccines are working. It's a lot of constructs coming where they're saying that even the vaccine may have limited efficacy, 1.6, 1.7, and the various vaccines may have various success rates. I think all this will be part of the thinking process. I think we've exceeded by 5 minutes. Thank you very much for bearing with me. At this point, I thank my co-panelists for an interesting, interactive, frank, provocative, and actually, brutally honest discussion we had. This is the knowledge available. Certainly, it's hit our ground. We need to message that is available in our pharmacy. We have to figure out how to do this. And with this final note, I hand over the podium to Sima. I will stop sharing my screen.
Thank you so much, sir. I thank Dr. Ravindra Mehta, sir, for moderating the session so well, driving such interesting discussions, also putting forward all clinically important questions and summarizing it all at the end of the session for all of us. Thank you so much, sir. I thank Dr. Matteo Bassetti, sir, for providing detailed overview of the product, also providing, letting us know about all the evidences pertaining to the Casirivimab, Imdevimab antibody cocktail, and also the real world experiences on its appropriate use. I thank him for the wonderful presentation, and I thank all our esteemed panel members, Dr. Rahul Pandit sir, Dr. Rajesh Varnakar sir, Dr. Vasant Nagvekar sir, and Dr. Subramanian Swaminathan sir, for sharing their expert views and providing the valuable guidance to us for on appropriate use of this drug. I thank our audience for spending their valuable time with us, and thank you all. Thank you so much. And we are signing off now. Thank you.
Thank you.
Bye, dear. Stay safe, all of you. Bye.